Hi there, my name is Mark Crockett. I'm an emergency medicine physician and president of the Emergency Care Division of PISIS. I'm here today to talk about healthcare information exchange. I think the best way to talk about it is to talk about the question that every patient has every time they go to the hospital or anywhere in our healthcare system, which is, why are they asking me the same question again and again and again everywhere I go in the organization? And why, when I go from one area of care to another area of care, why don't they know the thing that they just asked me 20 minutes ago working for the same company? So this is something that would never exist anywhere outside of healthcare, and we're just finally beginning to see a solution to this emerge, and it has to do with the exchange of healthcare information. So I can talk a little bit about that today, and of course we have some resources for you available at our website that you can catch up with later. The first thing we want to talk about is the difference between healthcare information exchange and IHE. HIE and IHE. HIE stands for Healthcare Information Exchange, and it's a broad, sort of general description of what you would be exchanging. IHE, which is commonly confused with it, is integration of the healthcare enterprise, which is a specific organization that has a lot of protocols for exchanging healthcare information. So think of IHE as a very specific subset of HIE, and we'll probably get along fine. Just to talk a little bit about healthcare information exchange, what would be the things that we would want to exchange on our patients, and what kind of areas would we want to exchange that in? I think the thing to think about there is the critical errors that we make in medicine. Some of the worst errors that we make are those when we have a patient in one scenario, let's say it's the operating room. We pass that patient from one area of the hospital to another area of the hospital, for example, the intensive care unit, and during that transition of care, something is missed. Often, one person is aware of the patient's allergies, a person's aware of the patient's medications. Those are, those medication lists, for example, they do call it the practice of medicine. And on that basis, it's really important to get those medications right. So those are just for example, to take those two things we'll talk about today, are two of the really critical aspects of healthcare information exchange. So if we look at a typical scenario, and we'll say that we're inside of the hospital, and in the hospital we have the operating room, and we have the intensive care unit, and we have the emergency medicine department. So in the operating room, the ICU, and the ED, these patients tend to go around together. So a patient who presents to the emergency department might well have appendicitis and go to the operating room. And when they're in the operating room, they have to have all of those medications, allergies, critical pieces of information. All of that has to be available to them. If all that information was available in the emergency department, and then the patient was medicated, particularly for pain, and is now a little bit confused, a little bit disoriented, and unable to give their history, clearly that's the kind of thing where you can see a drop in that information and a problem in the transition of care. As that patient passes out into the intensive care unit, post-operating room, they may still be under anesthesia. Again, that information should pass with them to those areas. And then the intensive care unit would basically pass that information again as we get out to the hospital floors. Now later on, we're going to see that the patient shows up to the doctor's office. Perhaps they had a medication allergy in the intensive care unit. How is that new allergy going to get out to the primary care physician's office? Obviously, the primary care physician is going to be talking to pharmacies. And so the number of people who have to be aware of that medication history, allergy history, and these critical pieces of information starts to really build. In the past, we have seen interfaces that have been able to carry some of this information. So if you had one emergency department system, and you had one operating room system and one ICU system, you were able to write an interface that would pass the information from the emergency room in this scenario. But very few people have one system that is effective for care in the emergency department, OR, ICU, out into the physician's office. And if you are a patient starting to look at the fact that you might find yourself eventually in a nursing home, and you might find yourself talking to an insurance company, and you might find yourself in another physician's office in another state. What you find yourself is all of these different areas. The hospital is only one small aspect of your care. A given hospital is one small aspect of your care. And so only when we have the ability to exchange the information outside of all these systems is the patient truly at the center of the data where they belong. And only then are we going to be able to take a patient across all these transitions in care and have them be safe. And I think the important thing to think about is which of these transitions in care is important and which one is risky. All of them. And in every single case do we have to have a situation that we can have that information pass. If you start to think, and you take any one area here and you start thinking, well, this physician office sends to another referral, so now we have a primary care physician and we also have a surgeon. Any one of these different areas can start to expand in complexity. And so when you start to think about creating point-to-point interfaces with some of the older technologies between these different systems, it was enough of a challenge to get a conversation going between the emergency department and the operating room, or the operating room and the ICU. Now starting to broaden that out, having point-to-point interfaces between all these different systems is just not tenable whatsoever. So enter the concept of healthcare information exchange based on a central repository of information. So in this kind of a scenario, if you have a central repository where all of that information could go and reside, that was based on standards, that all the information could be held in one central area, and any of the different systems that needed it could go and get that information, then that would be about the best possible current option to be able to move all this information around. Think of this as the central home for all the patient information. Now, for now, what I'm going to do is I'm going to consider a local area. So this is one organization. We'll talk a little bit later about what this would look like if you have multiple organizations. But in this situation, new concepts of integration have just sort of recently become something that we can talk about. And I think that we'll just talk about this repository as an XDS repository. XDS repository, and think of XDS as standing for a document server. Okay, what it essentially means is that at the point where you have done something significant in the emergency room, like update a patient's allergies or update a patient's information, you are essentially checking in that information into that XDS repository in the form of a document. Then when the patient gets out to another area of care, that system will check with the XDS repository and see if anything has changed. It loosely couples all of these systems together, but you can imagine the scenario. Patient presents to the emergency department unconscious. I have some basic information about the identity of the patient. I check with my XDS repository and I say, hey, is there anything that I need to know about this patient? And I get a set of allergies and medications. So now I start off with a list that's relevant, that's pertinent, that is the last known information about this patient. That XDS repository can give me a lot of information from a lot of different systems that have previously checked that information in and hand it to me as a single source of information. Later on, if I give medications in the emergency department, the patient now has an expanded list of possible interactions, possible problems based on the medications that we gave. And so when we're ready to transition, we check that information back in and update that list. So we have checked out, we have checked in, we transfer the patient, and now at this point the patient's in the operating room, and we check the information back out again and say, is there anything going on? It's important to remember that at any time while we're in the midst of this, any of these other systems could come up with new information that they want to contribute as it gets contributed the emergency department system where the patient is now. As you go through particularly critical events, like I'm going to administer a medication or I'm going to order a medication, this would pick this information up. Now we're talking about medication information because I think it's the biggest clinical piece of this. But you can imagine a wide list of pieces of information that people need to make good decisions. So this XDS repository is a repository that can handle a lot of information in a lot of different types. And there are standards for the type of information, things like pre-hospital records. So imagine an ambulance run where all that information is electronically available here. So when the patient comes in, gets to the emergency department, all that information is available. Operative reports, even things like images, so that when I get to make a decision on a patient, for the first time, I as a clinician have all of the information, and for the first time as a patient, I don't have to answer those questions anymore as I go from area to area.